Hello, I'm Dr. Bill Gradisher, Professor of Medicine at Northwestern University, and I'm pleased to be participating in this Yerbba YouTube video discussing management of menopausal symptoms in patients with breast cancer. One of the common consequences of therapy for patients with breast cancer is the development of menopausal symptoms. There are many ways that this can develop. Obviously, chronologically, a woman could go into menopause on her own time frame, but by getting certain therapies that we commonly use, such as chemotherapy, we can shut off the ovaries, and with that, we drive a patient from a premenopausal or perimenopausal state into a postmenopausal state. And similarly, there are certain anti-hormone therapies we use that can either mimic or amplify menopausal symptoms. And basically, the reason that these things develop is that in a woman, the ovaries are the primary source of estrogen. And with estrogen circulating, typically women don't have hot flashes or any of the other menopausal symptoms that I'll talk about. But if you shut the ovaries off fairly suddenly, either by the effects of chemotherapy or even anti-hormonal therapies that could shut them off even temporarily, or the effects of additive anti-hormone agents that interfere with the effects of estrogen, women can develop menopausal symptoms. And how are those manifested? Well, they come in a variety of different ways. Of course, one of the most common things that women are aware of are hot flashes. And hot flashes can occur because of the estrogen deprivation that occurs as a result of, say, chemotherapy or anti-hormone therapy. There have been a variety of ways of trying to deal with this. There is no perfect way of eradicating hot flashes, short of giving estrogen back, which particularly in a patient with hormone-sensitive breast cancer is exactly what we're trying to avoid. So in women who have hot flashes, there have been a variety of over-the-counter measures that have been tried. There have been things like acupuncture that have been useful in some patients, and obviously for some it's attractive because if it does work in that patient, it's something that can be done in the absence of adding yet another medication. There have been efforts looking at antidepressants, not because a patient is necessarily depressed, but one of the potential side effects that has been seen in some reports is that you can decrease the frequency and the intensity of hot flashes. And there are other things that have been tried as well. They have mixed effect in terms of diminishing the intensity or the frequency of hot flashes. And the other point of reassurance is that typically over time, and each patient is different, typically over time, the intensity and frequency of hot flashes diminishes, even if the patient remains on, say, an anti-hormone therapy. So there is a reason to think that this could be something that would be decreasing with the passage of time. The other things that I think we have to take into account is with chemotherapy or anti-hormone therapy, there can be a variety of other side effects. So for instance, women who take aromatase inhibitors, a common treatment for hormone-sensitive breast cancer, is to have an effect on bone density. So typically women who are postmenopausal, forget breast cancer for a moment, should be getting bone density evaluations every couple of years. And if their bone density starts to diminish, the risk of fracture over time can go up. And we often want to be aware of this because there are bone modifying agents or bone strengtheners. There are more simple things that can be recommended, including weight-bearing exercise, as well as calcium and dietary manipulations. So again, those things are critical over the long haul that have to be watched for and considered and talked to in terms of discussing these with the patient. Many patients will complain of vaginal dryness. This can be, for some women, simply an irritation. For some women, it can be a light vaginal discharge as a result of endocrine therapy. For some patients, it can be much more significant, causing interference with their sex life, painful intercourse, etc. So the strategies to overcome that side effect are multiple, including vaginal lubricants that can be purchased over the counter. There are also non-estrogen hormonal treatments that could be considered. And we also are okay with using low-dose topical estrogen or intravaginal estrogen, recognizing that the systemic, the amount of estrogen that gets into your system, would be extremely low, and the effect would be primarily local, meaning in the vagina. So in these circumstances, even in a patient with hormone-sensitive breast cancer, we don't have a high concern that there would be an elevated risk of developing a recurrence based on getting estrogen. And our goal is to mitigate the side effects so that patients' day-to-day life can be improved. Another side effect commonly voiced by patients is hair thinning. Obviously, if a patient gets chemotherapy, there can be hair loss. There can even be hair thinning using cold caps and other such devices to minimize hair loss. So that is very common. Similarly, with the use of anti-hormonal therapy, women can also get hair thinning. There are different things that can be considered. Obviously, we engage our dermatology colleagues if they have some particular insights. Drugs like minoxidil can be used either topically or orally, and that has helped with hair regrowth. And there are a variety of other topical things that could be considered with the help of dermatology that has made an improvement in the volume of hair that some patients experience. So that's another important side effect that can be a day-to-day impact on your day-to-day life. If you would like additional information, Yerbba helps patients understand their personalized treatment paths, including all the different therapies that could be considered that are appropriate for your situation, be that targeted therapies, chemotherapy, immunotherapy, or endocrine therapies, understanding how we make decisions based on the biology and health profile of an individual patient. You can also get a Yerbba report which breaks down chemotherapy regimens, other treatment options that are available, and understand the pros and cons of each of these options. And then finally, Yerbba medical experts can directly provide evidence-based answers to you about your options, recurrent risk, or side effect that you might experience with a given therapy. There are a variety of other side effects that are quite commonly discussed with patients and common that patients experience them. And that includes sleep disturbances. This can be as a result of hot flashes that sometimes wake patients up. They're not sure why they wake up, but they do. So again, the common things that we would tell any person, not even a patient, is to decrease any sort of caffeine before you're going to bed, to try and keep stimuli around the time that you're thinking about going to sleep to a minimum. Some patients, despite those maneuvers, still have sleep problems. And in those circumstances, drugs like over-the-counter melatonin or even CBT pills have been tried, and different patients express different levels of success with any of those different maneuvers. So I think any of those things could be tried in an effort to get a good night's sleep and feel refreshed, because that in itself can have an effect on other things such as your mood. If you're not sleeping, you're irritable, and you can that can be a consequence of not getting adequate sleep, but also mood changes can occur during the course of therapy and with some of these medications. So we have to take an inventory of any things that might be administered that you're taking not related to your cancer therapy that could be influencing that. Of course, if you're having significant mood swings that lead to depression, we would seek the care of a healthcare provider focused on psychiatry or psychology, and there may be a recommendation for antidepressants. With respect to antidepressants, particularly if a patient is on anti-hormone therapy, we have to take into account what the type of anti-hormone therapy is and what the drug being used to treat the depression might be, because there can be an interaction that theoretically could decrease the effectiveness of the anti-hormone therapy. So both are diseases we have to take care of, breast cancer and depression, but we want to make sure that we do so in such a way that we don't compromise the benefits to either treatment. The other things that I think we look for or ask patients about is whether they're experiencing any joint pain or stiffness. Of course, some of the medications that we use, such as aromatase inhibitors, can cause achiness in the joints. The more active a patient is, the more weight-bearing activity that they have, the less that they generally experience that. But even despite best efforts, some patients can still have some achiness. So for those patients, above and beyond encouraging exercise, we may recommend analgesics that help with that, or nonsteroidal analgesics that could mitigate some of those side effects, the goal being to keep the patient as active and in the normal routine as possible. So there are a variety of different side effects that we do see with medications we commonly use, but we have strategies that can be employed to decrease the likelihood that this would interfere with a patient's day-to-day life. And the final piece is weight gain, which is a common complaint that many women will have that they attribute to their treatment. Now, there are multiple reasons why weight gain could occur. Obviously, during the course of treatment, particularly chemotherapy, it's a common thought that patients are going to lose weight, but oftentimes they actually gain weight during chemotherapy because if they experience any level of, say, queasiness, not even nausea, one of the typical responses is stick something in my mouth. And if you do that enough times over the course of a few months, there is weight gain associated with it. Anti-hormone therapies as well can cause some weight gain. And we have to be very vigilant about encouraging patients to stay active, watch their oral intake, meaning calories that go in, not to discourage them from eating a good diet, but to monitor their weight and their oral intake so that they're not finding that they're gaining significant weight over the course of their treatment. And that's particularly relevant because patients who are on anti-hormone therapy will remain on it for years, a minimum of 5 years typically. The other thing that can happen, of course, as a consequence of therapy or just the passage of time is a premenopausal woman can become postmenopausal. And with that and the metabolic changes that can occur, weight gain can be a consequence. So it's a multifactorial reason that weight gain can occur, and it takes a strategy to look at any of the different elements that could be contributing to it in an effort to decrease or stabilize weight so that patients can maintain their normal habits and hopefully not be frustrated by weight gain. For patients who have significant issues with side effects, they often ask the question, can I stop the duration of therapy early? So we typically say a minimum of 5 years, and again, depending on risk, it may be longer than that for anti-hormone therapy. If patients are having significant problems with any specific side effect, they may ask, can I stop therapy? And our general recommendation is we know the data is best with longer durations of therapy, but of course we're not trying to torture patients. And we try to use all the strategies that I just explained to hopefully diminish the side effects that patients are experiencing, because the reality is if you're not taking the medication, you're not gaining the benefit from it. We also know that from multiple studies done over many years that even though patients may tell you they're taking the medication, it's very common over time, particularly when you're talking about a therapy that's measured in years, that the fraction of patients who are actually compliant and adherent with it diminishes with time. And interestingly, it's actually more common in younger patients than older patients. So it's something that physicians have, and any of the caregivers on the team, have to encourage patients and make sure that they are taking the medication. If they are having side effects, how can we encourage them to try strategies that would hopefully diminish that, but keep the patients on the anti-hormone therapy so that they can gain the benefits that we know come with longer durations of therapy. Sometimes when patients are on an anti-hormone therapy strategy for many years and they experience side effects, one thing that we consider is switching among the different anti-hormone therapy options. So as an example, there are 3 aromatase inhibitors They all have very similar side effects. They all have similar ability to reduce the risk of recurrence. However, for no good reason, sometimes patients do better on one than the other. So we will switch among them if need be. And furthermore, there may be settings where we consider, instead of an aromatase inhibitor, tamoxifen, particularly if patients are having significant arthralgias, achiness in their joints. That could be an alternative that would be viewed as acceptable and far better than discontinuing therapy. So hormone replacement therapy for patients with a diagnosis of breast cancer has sort of always been a black box warning. Obviously, in patients with hormone receptor positive disease that is stimulated by hormones, we would be very hesitant to make any recommendation that hormone replacement therapy was acceptable. Again, these have been long-standing recommendations to try and avoid it. There's been more discussion as of late about hormone replacement therapy and whether it truly is as unsafe as some people think it is, particularly in breast cancer patients. But again, our view is that particularly in hormone-sensitive breast cancer, giving hormones would be exactly the opposite of what we want to do. So I would still stick by the general rule that we avoid it. So I think the key takeaways on this YouTube video are that endocrine therapy, which we give for patients with hormone-sensitive breast cancer, and usually given over years, is highly effective. It's been demonstrated repetitively over the last 20 to 30, 40 years that by getting adjuvant endocrine therapy, you reduce the risk of recurrence. But it's only effective if you're taking the drug. So we have to encourage adherence and compliance with whatever's been recommended, but we also have to take into account what the side effects are and do everything we can to try and mitigate those side effects, which can be several. And we talked about some of those, including the achiness in the joints, the hair thinning, the mood swings, etc. These are all important day-to-day life factors that we have to have strategies to minimize. We want patients to lead their best lives even if they're still getting therapy. So addressing those issues is critically important so that patients feel like they're being heard. The other thing that we always encourage is exercise. Not only is it good for the mind and body, but it helps mitigate some of the side effects I talked about, including the arthralgias that some patients experience. We have a number of other strategies that can be employed that may mitigate some of the other side effects, including vaginal dryness, pain, and the joints, as well as hair thinning. And again, I think you need to speak with your healthcare provider about anything that's bothering you, because we want to make sure that you are adherent to the medication to decrease the risk of breast cancer, but also to acknowledge and address that some of these things also have side effects. So I hope you found this Yerbba YouTube video useful, discussing the symptoms that can occur in patients with early stage breast cancer receiving adjuvant endocrine therapy. And you can visit yerbba.com for additional information. Thank you.